Hello, everyone. Welcome to today's live broadcast, the Cure Educated Patient Webinar in CLL. I'm Christy Call, Editorial Director of Cure Magazine. We are pleased to bring you this webcast presented by Cure and in partnership with the CLL Society. We have a few important announcements before we begin. First, we encourage you to ask questions during the event, which you can submit by typing them into the Q&A box. You will also be receiving a survey via email tomorrow. As a thank you for watching the full webinar and completing the survey, you will be entered to win one of 3 Visa gift cards. We are pleased to be joined today by our moderator, Dr. Hun Lee, Associate Professor at the University of Texas MD Anderson Cancer Center, Dr. Earlene Seymour, Assistant Professor in the Department of Hematology Oncology at Karmanos Cancer Institute, and Mr. Terry Evans, Director of the CLL Society Support Network. Thank you for joining us today, and our moderator will now begin with the discussion. Thanks.
Hi, thank you so much for joining us for this patient education for CLL. This is a great opportunity for all of our patients to interact live in this virtual setting while we're undergoing this pandemic, which the country is under. And this is a great opportunity for all of us to learn more about this disease and treatment options available from the medical perspective as well as from the patient's perspective. I am joined by Dr. Seymour from Karmanos, and we have Mr. Terry Evans, who is a patient and has tremendous experience with CLL, and will give his input regarding the disease itself and the treatment he has received in the past. So we'll get started. You know, we'll start off with talking about the hottest item in CLL, and obviously the most exciting for the past decade has been the treatment development of Bruton tyrosine kinase inhibitors for CLL. As you know, Bruton tyrosine kinase has been a key molecule in the B-cell signaling pathway, and that has been studied extensively biologically, and now we have a great inhibitor of the pathway, which has garnered FDA approval, and there's many other second-line and possibly even third-line generations coming out. And we're going to get some information regarding how this inhibitor works from Dr. Seymour.
Sure. So as Dr. Lee kind of mentioned, BTK inhibitors, Bruton tyrosine kinase, it actually shuts down a pathway that naturally occurs. And it's important. It's an important pathway that helps CLL cells grow faster, proliferate. So the interesting thing about a BTK inhibitor is that it just shuts down that pathway. It doesn't target a mutation like we see with other types of TKIs, is what we call them. And so because it is on this B-cell receptor pathway, which is an important pathway for CLL, but also for lymphomas, it was heavily studied in CLL and lymphomas. What's really interesting about CLL is that we now know from the past decade that CLL patients respond very well to BTK inhibitors, or many of them do. And it was actually a breakthrough treatment for high-risk CLL. So for deletion 17p patients, previous to that, those were the patients that didn't do well with chemo immunotherapy. And Ibrutinib was another option that actually worked for those patients and improved our survival outcomes in those patients. So it is a breakthrough medication now for more than 5 years. I've had many patients on Imbruvica. Now there's also Calquence, and there's Brukinsa. There's many BTKs that are coming down the pipeline. And so it's not uncommon to see CLL patients who have been on these medications for years.
Okay, so prior to these BTK inhibitors, Bruton tyrosine kinase inhibitor, the standard of care has been chemo immunotherapy. What were some of those drawbacks or difficulties our patients were having with the chemo immunotherapy?
So if you kind of go back, let's say a decade and a half, 2 decades ago, like a lot of the chemos that we use, like fludarabine, pentostatin, they were very prone to infection when patients took those medications, and sometimes they weren't very tolerated, particularly if you put FCR, if you put fludarabine in combination with rituximab cyclophosphamide. Younger patients may do okay with it. Older patients did not tolerate that regimen as well. And we have updated studies that show that, particularly if you are over the age of 65. So biggest drawback was those combination therapies. You had opportunistic infection, you had small but serious risk of secondary malignancies, you have also pretty bad toxicities with fludarabine in particular. You could get very bad, what we call hemolytic anemia, where it breaks down your red blood cells very quickly. There are serious side effects with the older chemos. We also had, for high-risk patients, like I mentioned, sometimes those chemotherapies were not working for those patients. We had drugs like alemtuzumab, again, very prone to what we call opportunistic infections you wouldn't otherwise get. So there were tricky side effects from older chemotherapies. But that being said, they were still effective. So FCR is still effective now, we know, in a subset of patients with mutated IgDH still. But I guess the biggest breakthrough for chemoimmunotherapy then was bendamustine in like 2008. I keep forgetting that that actually is, even though it seems so old to us now, it was actually quite new and just approved in like 2008. So BR was approved for CLL back then, and that was more tolerated. So that was the biggest breakthrough prior to the BTKs, because that was a chemotherapy that was a little bit better tolerated, and it was given as an outpatient. Mm-hmm. Again, it wasn't without effects.
So we have our first question from the audience. What are the benefits or risk of stopping ibrutinib after number of scans show negative MRD? Okay. What are the benefits or risk of stopping ibrutinib after number and scans show negative MRD? So that's a very good question. Obviously, this there's many parts. Stopping ibrutinib, and then, if the scans show negative MRD, I guess whether they're talking about PET scans here or flow cytometer, that's the most common use of minimal residual disease. So there were many studies that have been shown that if you are able to get into a minimal residual disease, that you do better. But however, these are still a very research question oriented. I know that MD Anderson group just published, I believe last year, on the venetoclax ibrutinib study, where they gave 24 months and measuring MRD and then stopping the drugs. And yes, many of the patients had negative MRD on flow cytometry. I don't think in CLL they're using PET scans right now for MRD assessments. I think they're more by flow. Dr. Seymour, can you comment on your practice? Are you incorporating minimal residual disease as part of your treatment strategy?
So I think, like you said, Dr. Lee, minimal residual disease we're using more currently in clinical trials and more in combination therapies that I've noticed, not in monotherapy, ibrutinib, and then discontinuing and then checking MRD. So where I've seen it used the most is in combination with Imbruvica, with venetoclax, and now we also have triple therapies that are trying to answer, if we can get patients to MRD negativity, can we stop therapy? That's kind of one of the reasons we try to check. And we're also trying to see if that's a good measure. And actually, a few studies have shown it may be a potentially good measure to tell us whether we're going to achieve a long progression, what we call progression-free survival. But it's not, again, like he just said, I don't use scans to check for minimal residual disease. Most of these studies will use flow cytometry. Some of them will also do concurrent bone marrow. There's a just very tiny overlap of difference between the two. But it's not something that I use mainstream, particularly for Ibrutinib. I think once some of these studies finish, particularly the cooperative studies, we'll have a little bit better direction as to what to do with it.
I agree. I mean, we had the study here. I think there's a Captivate study, which is addressing Ibrutinib venetoclax, and they randomized based on the MRD status after 12 months of treatment. These are very exciting treatment strategies coming up. Can you think of any risks that are involved by stopping treatment? What are some of the risks that you can think of by stopping treatment because the patient has a negative MRD, so we should stop treatment? What could be the possible theoretical risk?
So, I mean, theoretical risk is relapse. For some patients, particularly if we're stopping, we actually are very careful when patients are progressing on Ibrutinib not to stop it immediately. And we don't have the answer as to how long will someone relapse after MRD negativity, particularly for Ibrutinib monotherapy. But I would say that that is probably another question that we're going to try to answer later on when we have a little bit more information as to what happens with when patients finish these time course therapies. And back in we can look at CML in terms of, they had a marker that they looked at, BCR-ABL. They now have ways to discontinue that drug after several years, and we're just not there yet. But I think that could potentially be something in the future to look at.
I agree. I think that will be something. The second question we're getting is the triple therapy, I guess they're referring to Imbruvica, Venclexta plus a CD20, whether it's rituximab or obinutuzumab, the triple therapies that are currently being studied under clinical trials. Would that be a frontline standard of care? Would that be a standard of care? Have you started on a triple therapy on it's not standard of care right now, but these are clinical trials that are going on. Can you comment on the triple therapy? What has your experience with the combinations?
So my experience with the combinations is you do definitely have to look at like blood counts dropping, fatigue. It's not without side effects, the triple therapies, and I say that from experience from clinical studies that are actually ongoing right now. So we're trying to answer that question: is triple therapy given over just a course of a year or two versus Imbruvica with obinutuzumab, or maybe just Imbruvica by itself forever and ever and ever, like we give it as by itself? Which one's better? So there's actually several trials. There's 2 cooperative studies that are trying to answer that question right now. So is it potentially going to be standard of care? Wait and see. But it is definitely a difference in side effects.
I totally agree. Terry, have you had any what has been your experience in terms of the chemo immunotherapy that you have had in the past, and what can you share with our audience, your experience? Because remember, chemo immunotherapy is a fixed duration therapy, and it's a little bit tougher compared to the oral therapies, but 6 cycles and you're done. How was your experience with these infusional therapies called chemo immunotherapies?
Well, I think everybody, as you know, every CLL patient reacts differently to the treatment regimens. There's no one size that fits all. And Dr. Seymour hit on something that actually happened to me. I had FCR as my first treatment, and I did develop autoimmune hemolytic anemia because of that, and actually it had to be cut short. So, there are risks and side effects of every treatment, including oral treatments. But you're right, the traditional chemotherapy treatment is typically, like 6 months and done. And a lot of patients like that as opposed to saying, well, I have taken oral therapy, and perhaps you may have to take that oral therapy for the rest of your life. I've been on Imbruvica for 7 years, and, you know, I mean, there are some side effects to it, but it's a pretty easy regimen to go through when you're just talking about having an oral drug, and much easier in terms of the time required. Infusions require you to be at an infusion center or medical center and be treated that way. So it's time spent in the doctor's office or medical center, where oral therapy, you do it at home. So they're really, it's a lot easier for the patient, I think, to do. And I did add venetoclax to my Imbruvica about 27 months ago. So I've actually now been on both of them for a little bit over 2 years. And I'll say, you know, relatively easy treatment compared to the side effects of chemotherapy.
So so if I can ask you a question, if you could go back to yourself 7 years ago, what would you tell yourself to ask your doctor? You know, what are some of the pertinent questions for many of our newly diagnosed patients who may be listening into this? What would have been the question you would have told your former self 7 years ago going into this oral therapy with Ibrutinib or Imbruvica?
Well, you know, I'd like to know the results of it so far, whether that's through clinical trials or through other patients. I would also really like to know, you know, how many patients does the doctor have with that treatment? How experienced are they in it? I would recommend getting a second opinion, just as a way to balance your options, to make sure that, you know, some doctors may prefer one over another, and you need to figure out why they are suggesting one treatment over another. So I'd say do a little bit more research. I did not in the very beginning, and I think it cost me a little bit because I didn't make the investment in education and trying to learn a little bit more about my disease. That's why seminars like this, webinars like this, are so important to patients, because it allows them to get information that they maybe don't get in their doctor visit. And I think these are extremely important from a patient point of view. It's just educating yourself.
I totally agree. You can never go wrong with investing in yourself in education. Okay, that's, you know, this is coming from a Korean person, so you know, right. We're all hardcore in education. So Dr. Seymour, how do you decide between an infusional IV chemotherapy from a oral-based chemotherapy in your practice of a newly diagnosed CLL?
So that's changed a bit.
I know it's
so that's changed actually quite a bit.
Yeah.
So let's say I'm just going to kind of lay out what are the options right now that we've approved.
Yeah. So let's say you have a young patient.
So say we have a young patient, you know, FCR is still there, but I'll just I'll go through my mindset as well. So let's say we've got some options. So FCR is an option, Imbruvica is an option, and honestly, like, where you can still think that maybe venetoclax, obinutuzumab, venetoclax, and rituximab as well. Okay, so those are those options that we think about.
It's not FDA approved yet.
It's not
right,
FDA
for
approved.
frontline therapy.
It's the obinutuzumab with Ben is, but not specifically for younger patients. You're correct. But anyway, so that option, which, you know, I'll just put it there, but it's not. You're absolutely right. It's not specifically for younger patients. And younger patients mean less than 65. So what do I do? First things first is still indications for treatment haven't changed. So you have to kind of meet an indication for treatment. But at that point, I would check 2 tests. CLL FISH is one of them. So that looks at your deletions. And that tells me whether you are a high-risk deletion 17p is the highest risk. But it also tells us some other like intermediate high risk deletion 11q, and then there's 13q, which is actually a rather good prognosis if that's the only thing you have, and trisomy 12. So those are you see this panel when you get that FISH testing. And the important part of that is to try to stratify your CLL, particularly if you're 17p, and sometimes even if you're 11q, if you have a clinical study for those patients. The other test that I like to get is that IGVH mutation analysis. I used to not get that as much. It used to just be a prognostic test, but we didn't really change therapy on that. But that is to kind of see whether you can tease out whether you are mutated, which is actually better prognosis, which is not intuitive to many people, but mutated, it means better prognosis. And in that small, percentage of patients who are mutated, we see that, okay, let's FCR chemoimmunotherapy and Ibrutinib, you have pretty similar outcomes, but only for mutated IGVH. So those are two reasonable options for mutated. If you're unmutated, however, we actually have now good mature evidence that Imbruvica is a better choice in terms of clinical outcomes. So that's how I think of the patient.
Okay. So we have an audience question for Terry. So one of our audience member is asking the question, why was the venetoclax added? So we have an audience member who has been on Imbruvica for 4 years, and he or she is asking, why did you, Mr. Evans, add on venetoclax to your Imbruvica?
Well, at the time I relapsed, they ran a genetic testing on me, and they found out that I had developed a mutation, which sometimes happens with long-term Imbruvica patients. It was a mutation of C481S. And because of that, they knew that I was going to relapse eventually completely. My numbers were still not really bad, but because they had been creeping up slowly, it was decided
numbers, what do you mean by numbers?
Well, my white count, specifically my ALC numbers, had been
lymphocyte count.
Correct, and really my lymph nodes were increasing in size a little bit where they had basically gone away before. So my medical team knew that I was relapsing, and so I went out there to try and find out what I could do now, because I have all the bad prognostic markers. I have 17p, 11q, I'm unmutated, and so my treatment options were really limited. And so it turned out that I wound up getting in an investigator-initiated trial where I was going, where they decided to add venetoclax to patients that had developed a mutation but were still responding to Imbruvica. So they added the venetoclax or Venclexa, and what happened was that within 2 weeks of starting the Venclexa, my numbers had, my ALC and my WBC, white blood count, had gone to the lowest levels they had been in 8 years, which was all the time that I had been on Imbruvica. And they ran a test to determine the depth of the remission, and at the 11-month mark, they found that they could find no evidence of disease. So it seems to my medical team that by adding the Venclexa to the Imbruvica, they looked at it as a 1-2 punch, and where the triple therapy is like a 1-2-3 punch, this is basically attacking CLL from 2 different pathways, and it seems to have proven out. There are a number of studies now that have been started with specifically that in mind, because now you have a lot of patients that have been on Imbruvica for a longer period of time, 4, 5, 6 years, and once they relapse, the question is, what do you want to do with those patients? What is their next step, so to speak?
Okay, so that was a very good explanation why you were added on to the venetoclax, because you had some progression. We have another question who is asking, I am quite successful with Imbruvica alone. I bring up other options. Blood work is normal, no disease detectable at this point. I am 11q mutated. Okay, so I think this goes back to Dr. Seymour's recommendation of looking at what we call the FISH, which is a fluorescent in situ hybridization, and looking for genetic abnormalities that are seen. The next question is, and we have a patient who has not been treated for 14 years. Dr. Seymour, what is the longest watch and observe patient you have had in your practice?
So honestly, I have to think back to fellowship because they exist. So there could be, I think the longest one has been more than a decade. And honestly, I don't even know if she's been treated yet.
Okay, so what are some of the signs that you look for when you have to say, okay, we need to get started with treatment options, to think about treatment options?
So we look at symptoms. Symptoms
what are some
important.
Of the features that you look for?
So sometimes it can be fatigue. Sometimes it can be significant fatigue, and so not just that I'm a little tired today, but profound fatigue. We still look for what we call B symptoms. So night sweating through your sheets, weight loss, and other symptoms that suggest that you have a much more active, aggressive cancer now. We also look for other things. So sometimes your spleen can get so large that it's painful. That's a very common presentation. Sometimes your lymph nodes grow so large that either it's cosmetically not pleasing, or maybe it's impinging on a vein and you're getting clots. So if your lymph nodes are causing problems, and sometimes they can grow so close together and make a big mass and cause problems, that's a good reason to treat. So we look at bulky disease as a reason to treat if it's causing problems. The other thing, if your white count, well, not your white count, but your red blood cell count and your platelet count are dropping, and we think it's because your bone marrow is getting full of CLL cells, that's a good reason to treat. So we look for those things in your lab work and your exam. So it's really important to relay any kind of symptoms you may be having.
Well, Dr. Seymour, it's really...
we have a lot.
Dr. Seymour, I just want to say that a lot of people think that when their blood count reaches a certain number that they have to be treated, and that's not necessarily true, correct?
Correct. So sometimes it's very common for patients to see their counts going up and get any kind of anxiety because we see it going up. But I have seen patients even in the hundreds with normal blood counts with no symptoms. So we definitely have patients who have high counts. We don't treat just based on a count, but we look at the whole. This is why we see you every so often in clinic, because we have to look at the whole patient and look for a good reason to treat.
Right.
I totally agree with Dr. Seymour. The number is not what we treat, but there is something called a doubling time, lymphocyte doubling time. And if the doubling time becomes shorter and shorter, we do tend to intervene if your numbers are going up very rapidly compared to previously. We have another question regarding mechanism of action. What is the difference between Imbruvica and venetoclax?
That to me? So
Imbruvica,
so Imbruvica, like I mentioned, shuts down the B cell receptor pathway. So that's a pathway that helps your CLL cells grow rapidly. Okay. So the Venclexta, I have to get used to that. Venclexta is a BCL2 inhibitor. And so its mechanism of action actually drives a pathway that helps kill your cells, so helps kill CLL cells. It drives that to happen faster. So we actually see when people are on Venclexta, it can work pretty rapidly. Sometimes we have to put patients in the hospital to watch their electrolytes because we can see something called tumor. We're monitoring for something called tumor lysis syndrome because the cells are just dividing rapidly, and we need to watch out for toxicities.
So next question is for Terry. Audience is asking, what are the arguments for staying on Imbruvica if the Venclexta is possibly responsible for the improvement of your blood work?
Well, that's why it's a clinical trial. I could have gone straight to Venclexa, but it seemed like because I had responded so well to Imbruvica for a number of years that it didn't seem like to be too big a risk to continue on that drug. I had very few side effects from Imbruvica, so the thinking was, let's just keep you on that, and then we'll add this drug to it. And there's now talk with my medical team about taking me off of Venclexa, but still keeping me on Imbruvica as kind of the placeholder. It's kind of like my security blanket now. I'm kind of used to taking it, and I don't really want to stop it necessarily without reason. But, most of the time, a lot of people stop these drugs, the oral therapies, because of adverse events. And because I really haven't had any, the thinking of my medical team was, let's try and attack this from 2 different points instead of 1. And see if we can get more bang for our buck by the combination therapy. And I think, as Dr. Seymour said before, I think the combination therapies that are in trial now are the ones that are really having some great success in terms of attacking the CLL from different points of the cell.
So there's a question from the audience coming to Dr. Seymour regarding your observation and recommendations for watching and waiting. If a patient is on a watchful wait, but has very itchy skin, slightly enlarged spleen, bone marrow involvement, low platelet, high LDH, low IgA and IgG, so you recommend treatment if the patient don't have any other symptoms?
Well, I mean, it sounds like
a tricky situation. Yeah.
Yeah, it sounds like that patient has symptoms. Sometimes, so it sounds like I mean, that's a whole list of kind of flags that we look at. So we want to know, why do you have a high LDH? Is the skin because of skin involvement with CLL, which I've seen? So, and are you itchy from that? I would actually consider that symptomatic too. But if you're having like a whole slew of problems and your LDH is high, I also would want to look into that further. Sometimes, rare cases, you can transform to aggressive lymphoma, and so we want to evaluate that a bit further. But it does sound like, with that list of symptoms, you may have. Just want to dig a little bit further into whether you have symptomatic skin involvement and make sure you don't have transformation.
Okay. And the next question comes back for a little bit of a pharmacology question. What are the differences between Imbruvica and venetoclax, especially in patients treating 17p deletions with CLL?
Differences in treating 17p is the question?
So I think the question the audience is asking, the mechanism of action of Ibrutinib, Imbruvica, how the mechanism works for 17p and for venetoclax. Why are they chosen over chemoimmunotherapy? Why you would not give chemoimmunotherapy to 17p, but you would give Ibrutinib and venetoclax?
So we've actually shown in clinical studies. Because even prior to those drugs being on market, we know that with the classic chemoimmunotherapies, they didn't have as good progressive-free survival or overall survival in patients with 17Ps. It was a tricky subset of patients to treat. So we were thinking of things like alemtuzumab at the time. With ibrutinib and venetoclax, we finally saw an improvement of that survival curve. And they're actually kind of similar if you just look at them by itself, ibrutinib by itself and venetoclax by itself. But there was an improvement in progression-free survival in those patients. And so that indication, particularly for Imbruvica, that was early for 17P patients. We were very excited about that because the other options were not as easy to take. So we now have, based on your FISH, you can check like almost the classic survival curves, and we can see that 17P in combination therapies, but also in monotherapies, we are improving how long these patients are disease-free. But we're still paying good attention to these patients. If I see one, I try to get them on a clinical study if I have a 17P study, even frontline.
Okay. So we're going to move on to the next topic that we're going to be talking a little bit more about this shared decision making, how we come to a conclusion. As you know, there are many trials and decisions between physician and patients have to come to a compromise. And we're going to start talking how to come to a decision regarding the efficacy, the quality of life, what kind of side effects. What are some of characteristic patients, Dr. Seymour, you would give Ibrutinib to based on efficacy, quality of life, side effects? Is there certain types of patients that you are classically going to give Imbruvica?
So let's just think about CLL as a whole. Like most patients are older age. So very commonly we're seeing older patients, and this is a great drug for older patients. It's well tolerated. It's definitely less side effects than chemoimmunotherapy, even bendamustine and rituximab, albeit it's not a treatment, it's not a short duration of treatment. So patients who are almost your typical CLL patient, mutated or older, those are good patients to consider Imbruvica. 17P patients, certainly. I try to delve into clinical trial options for those patients too, if I have them. But that is still a good option for 17P patients.
Okay, so Terry, in this decision-making process, which is very difficult, as you know, chemoimmunotherapy and all these targeted agents like Imbruvica, venetoclax, rituximab, obinutuzumab, idelalisib, and all these agents that are coming down and in development, it's great. But that leads to almost like an decision paralysis because you have so many choices now. If you go back 15 years, you only had chemoimmunotherapy, but now it appears that you have lots of options, which has its own drawbacks when you have too many options. Right. One question I would say is, if you could go back to your, when you first got diagnosed, what would have liked your doctor to have informed you, or what are some of the things that the doctor could have improved upon so that you would have made I don't want to say better decision, but more of an informed decision?
Well, when I was diagnosed 20 years ago, and so at that time there really were only two options. You could get a bone marrow transplant, or you could go with FCR, which was really technically not even approved yet by the FDA, but it was used in combination. And so, there really weren't a lot of options, but the landscape has changed so dramatically in the last, I'd say 5-7 years for patients that you're absolutely right. It almost now you have to pick and choose one of, 2 or 3 or 4 great treatments that, have shown really great results in patients. And I would say if you're going to try and make this decision, what you need to do is find out, how comfortable is your medical team giving this particular regimen that they are offering you. How many patients do they have that are currently on that? I would agree with Dr. Seymour. that if there's clinical trials available, that you seriously look at a clinical trial. You know, people have this feeling that a clinical trial is you're like a guinea pig, and they're not going to, you know, really keep your best interest in mind. And I've been on 3 clinical trials, and I can say it's absolutely the opposite of that. I felt like I was taken great care of by my medical team. They obviously need more information out of you in a clinical trial, and there may be extra tests run and things like that. But the amount of care that your medical team gives you in a clinical trial environment, to me, was just superb. But, you know, if you're not at a place that has clinical trials available to you, then I would want to know, you know, what their, you know, experience is with the drugs that they're recommending. I would say do a little bit of education on your own. Maybe add an appointment with maybe a CLL specialist, somebody that treats the majority of their patients that have CLL, just to get a second opinion about, you know, number one, do you need treatment right now? And number two, what would be the best options for you, given your genetic and prognostic markers? Because, you know, like I said, everyone is different in this, and I think it has to be a shared decision with you and your medical team and your own internal support team of, you know, can you afford to, you know, be in a clinical trial where you may have to travel to be there? Is that something that you can easily do? So there are a lot of factors in the decision, but the bottom line is, you have to feel comfortable with the medical team and what they're prescribing for you. And I will say this because it's happened to me. If you're not comfortable with that, try and find another doctor that you are comfortable with in terms of relating to them and looking at options that are available to you, because you're advocating for yourself. This is your life you're talking about. And you need to really be comfortable with not only what you choose, but also, you know, the team that you're dealing with.
Okay, that is a great. What are some, you know, if you could give us, you know, 1 example or 2 examples regarding how we can, you know, how can the patient really advocate for that, you know, for themselves and to improve the patient-physician relationship? What should they be looking for, or what can they do to improve that relationship?
Well, you know, as part of our support group, we always tell people that they should try to take somebody with them to the appointment, just so you have another set of ears listening to what their doctor's saying. I've had a number of doctors say, I don't want you taking notes. I want you and I to be talking. Somebody else can take notes. I record all my visits because I'll go back and even if my wife goes with me, we'll have a disagreement about what was actually said. And then if we go back and actually play the recording, we can actually figure out what it was. So I think that, you know, getting as much around you in a support system is really important, and you know, sharing that information with your doctor, you know, and make sure you tell your doctor, you know, everything that's going on with you, and don't save the, you know, the biggest question for when they're getting ready to walk out of the room. Make sure you prioritize your questions for your medical team so that you hit the most important things first. And then you can go to things that maybe are not quite as important, but also share with them, you know, oh, I started a new diet of beet juice. Well, they're going to want to know that. They're going to want to know, have you made any changes to your, you know, to your supplements, especially. But those are things that people sometimes don't think about in their visits with, you know, in their clinic visits with the doctors. But it's really important for the doctors to understand everything that's going on with you, you know, and not just saying, you know, oh, you know, I have this slight pain in my heart. I don't think it's a big deal, but it could be a big deal. And those are the things you need to share with your medical team and be completely open.
So one other topic that we wanted to really cover, now that many of our CLL patients are living practically almost normal lifespan and living decades after diagnosis, like Mr. Terry here, who has been with this diagnosis for the past 2 decades. And now more newer treatments come out with better tolerability, with better disease control. Now it's turning into more like hypertension, diabetes, where the word cancer used to scare us, but now we're really trying to control the disease. Dr. Seymour, moving forward, you will have more of these patients that will be coming to your clinic. What are some of your strategies to try to mitigate kind of like the side effects and the long-term toxicity that may be coming with these long-term treatment options? And we agree that the field is changing very rapidly. But what is your strategy? Now you have a patient who's been on Ibrutinib for 7 years. What are some of your strategies to keep these patients maintain the quality of life that they have?
So 7 years, it's usually those patients, I'm going to back up just a little bit. So when you're just starting, I actually see you a little bit more frequently at the beginning and then try to span out. That's important because we want to see how your side effects are on the drug. A lot of the side effects can be worse at the beginning and then they get better over time. So we look for that. So say you are a 7-year out Ibrutinib patient and now you're getting like joint pains and maybe some hypertension. We still have to look for chronic side effects and treat them. So if it's joint pain or if it's something that's just, even if it's like what we call grade 1, 2, and it's really just bothering you, sometimes that's an indication to say, okay, this BTK is working, but is there another one we can try just to see if the side effects will go away? So I think that's where we're going with this. There's lots of BTKs coming down the pipeline, and soon we will see if there's differences in toxicity profile. So we can switch you, and we can follow that model from another very chronic myeloid leukemia. They have similar what they call TKIs, and they have different toxicity profiles. And so if one is giving you bad side effects, then we try a different one. Or a totally different area as well. You could switch to venetoclax.
Yeah. So you have so many options now, and this goes back to the same question that I asked Terry regarding, so many options. There's going to be some paralysis on many of my patients that come in. They have difficulty making any decisions, or they go, Dr. Lee, what would you take? What would you give your mom? So those are some of the questions I get. And I totally agree. Given the options are increasing exponentially in the past 5 years, the number of drugs that are being developed, and it's just going to increase, I think, faster over the next decade. So this question for Terry, what is your thought on the right balance of living life and patient education? What has been some of your what I call learning moments? I should have done this. I should have, had this question ready 10 years ago. What are some of those key tips, what I call the pearls of wisdom that you could give to many of our patients who are coming in, maybe newly diagnosed, maybe they're, relapsing at this point?
Well, one of the things that I think faces a lot of CLL patients is when I was first diagnosed, for the first 7 years of my diagnosis, I was watch and wait, and I knew no other patient with CLL. And in about my 8th year, I joined a support group. And this support group actually became the CLL Society, supporting only CLL patients. And I would say that if you can join a support group, that the benefits are just tremendous. We have patients that are newly diagnosed and going through that deer in the headlights phase. We have patients that have, had multiple treatments, and trying to share your experiences with other people who may not know anyone with CLL, I think is really important for us in the CLL Society and the support groups. We have over 35 support groups in the United States and 2 in Canada. It really is, we've gone to a virtual format, obviously, because we can't meet in person. But I think the benefit of knowing people that have this disease, see what they've gone through, learning from their experiences, is something that I wish was there when I was first diagnosed. And now it is. And I really encourage people to, you find after a while that CLL does not have to control your life. Yes, it's a chronic disease, and yes, I may have it for the rest of my life, but the way it's being managed now, either through, a treatment that you may have to take for a number of years, or even, the fixed duration treatments that are now coming out, the outlook for patients now is so great in terms of long-term survival, in terms of side effects from adverse events from current treatments. And none of this existed 10 years ago. And the landscape has changed so much that I think you have to have a balance. You have to live life. When I asked my doctor, well, should I go on vacation? And he told me, you need to live your life. You can't let this paralyze you in terms of thinking you can't still do anything. And of course, with, COVID, we're a little bit more careful than we used to be. But as a CLL patient, having a compromised immune system to begin with, I was already washing my hands. I was already staying away from sick people. So it's just kind of a, outgrowth of that I'm, become even more careful in terms, but it wasn't really anything new to me or to the people that I know with CLL. So.
Okay. All right. A couple of audience questions that I'm going to read out to you guys. This is for Terry. How do you handle the waiting for the other shoe to drop when the outcome of relapse is possible with 17p deletion? How do you handle the waiting of the other foot to drop? Okay.
Well, yeah. Even though I'm MRD undetected and have been now for almost 16 months, I'm not under the illusion that this will never come back. In fact, it probably will. And because I've been through 6 treatments, I kind of know the game. I kind of know, that, yeah, I'm going to relapse and it's going to happen. So what I tell people that what I'm doing is I'm always looking at the next step. I'm looking at what is out there that I can do, what treatment options, what clinical trials. I've seriously looked at CAR T as an option because I've run through just about every treatment out there. And so as opposed to a bone marrow transplant, their stem cell transplant that really had a lot of issues in terms of toxicity and after the transplant, even if you get through it okay. CAR T has shown some amazing results happening in CLL patients. And I think that may be where the future lies for patients, especially ones that have been through a number of regimens and failed those regimens. Well, I'm going to run out of options at some point in time. And so I have to be aware of what my next steps are going to be. And, I seriously think that, CAR T, it's still in trials, obviously, but the results out of some of those trials for CLL patients, I think the treatment protocols are getting better and better with CAR T in terms of managing the side effects of CAR T. But, it's a month basically of treatment and you're done, and hopefully there's no disease. And so it's much.
I don't want to say it's done, but yes, that will be a good segue. Dr. Seymour, can you kind of give us the 411, the CAR T 101 talk? It's a CAR T. Can you tell us a little bit the description of the CAR T that Terry was alluding to?
Got it. Okay. So you've got white blood cells in your body. Then some of them are B cells, which are part of your, you have an abnormal B cells, which are CLL cells. And then your T cells also help with your immune system to fight off infection. If you have trauma, it comes and helps out there. So your T cells and B cells help with your natural immune system. You have normal B cells and T cells. So what CAR T does, and this always sounds like science fiction when I explain this to patients, we take your natural T cells, we collect them, send them to a lab where they bioengineer them to target. It could be CD19, it could be CD20. Right now, most of the studies are CD19 for CLL. So they then reintroduce that simply by infusion, but it does come with side effects. But then the intention is to give you your own T cells now re-engineered to recognize your CLL cells and help your immune system attack your cancer. It's a pretty amazing. It's a big feat in CLL. It's a big improvement on lymphoma. So it's a really exciting therapy. And you're absolutely right. We're actually thinking about this even before bone marrow transplantation. We're not seeing as much bone marrow transplantation for CLL because we have these new oral therapies and because we have these promising clinical studies.
Yes, CAR Ts are very active here at MD Anderson, and we have seen some phenomenal responses. And there's not only CAR T cells, there's CAR NK cells, and now there is development of what's known as off-the-shelf CAR T cells that are coming down. So this field is changing very rapidly. And if we have this patient education next year, I know that it's going to be filled with CAR Ts and cellular therapies that are really going to be moving forward. There's one other audience question that I wanted to get to is a very under-recognized, which is how to manage mental health in patients with CLL. As you know, many of our patients with cancer, whether it's CLL or any other cancers, there's definitely higher rates of depression and difficulty coping. So, if I can get a comment from Terry, were there periods in time in your treatment period you had difficult time, and how did you cope and manage those difficult periods during your treatment?
Well, obviously after the about third time I relapsed, I was really getting tired of this. It just seemed like there was a never-ending cycle. But I will tell you that, for me personally, I think family is really important. Faith is really important. I think your spiritual side of your journey. I think sharing these feelings with other patients, which, in our support groups, we have patients and caregivers. And sometimes the caregivers are having as much of a mental health issue as the patient is, because here they see their loved one that's either, going downhill or not doing well physically, and they have to deal with that as well. And so it is a topic in our meetings about, how can you better manage this? And, somebody asked the question once, is anybody in our group depressed? And you should have seen the show of hands. It's like, yeah, it's almost normal that this would happen to you. But I think, if you can talk to somebody about it and just maybe share what you're going through, I think that's really important. And, if you brought this question up to your medical team, they have referrals that they can give you for help and support, social workers or people that can help you through this. So don't ignore, the whole spectrum of help that's available to you. And I know typically men don't like to man up and say, well, I'm just feeling down. Well, no, you could actually be depressed. I hate to tell you this because, and I think you need support. And you need, friends, family. I have a great support network, and I literally share everything with them, and I think that helps me. It helps me, you know, even doing programs like this. It helps me to kind of share my journey with them. And you know, here I am, 20 years out with you know, failing bad prognostic markers and failing all these treatments, and yet now they can't find any disease. So you know, it really, there is light at the end of the tunnel for, I would say, most CLL patients today.
Okay, so unfortunately we are out of time. If you'd like to watch this webinar on demand, it will be available curetoday.com webinars within the coming days. I want to thank the panelists and the audience for their attendance participating in today's event. I would like to thank our partners, Cure and the CLL Society, for making this educational webcast possible. Don't forget to check your emails tomorrow to please fill out the survey and to enter yourself in for the raffle. And thank you all for joining. And we will see you next time at Education Patients in CLL. Thank you very much. You guys have a good day. Good night.
Good night.
Good night.